Nice, nice. Welcome, everybody. My name is Marty Mascari. I am a contractor with the North Central Texas Council of Governments under the Area Agency on Aging and the North Central Texas Aging and Disability Resource Center, ADRC. We're blessed to have my boss, Donnie Green, who's the director of the Area Agency on Aging and the ADRC, and cohort Jamie Harwell here to talk about or to give us an experience with Virtual Dementia Live, and then talk about the services that Dementia Friendly North, Central, and East Texas have available. But before we get started, I'm going to go over the CEU's information for those of you that are looking to obtain CEUs for today's presentation. We are set up to provide CEUs for licensed social workers and licensed professional counselors in the state of Texas. You are more than welcome to go through the process and get a CEU certificate if you have a different license in Texas or you have a license outside of Texas. I've had people tell me they've been able to use them elsewhere, but please note, there's no guarantee. And if you do have a problem with that jurisdiction, there's not anything I can do to help you. We're just set up with these two. We also offer certificates of attendance if you're interested in one of those as well. The guidelines for both are the same. You must complete the entire live webinar and the Q&A. And today's presentation is worth 1 hour of CEU credit. But this is a little bit different, just so you know, if you've joined us in the past, our various webinars have different CEU requirements. And this one's a little bit different. And so please listen closely. You're going to need to complete both the SurveyMonkey evaluation and the Google survey evaluation in order to obtain CEUs for today. We have to have both of those, and we'll be triggering off both of those in order for you to get your CEUs. So please make sure you complete both. Neither of them are set up to pop up as you close out of Zoom today, so don't look for them there. They will both be emailed to you in the follow-up email. There'll be 2 different links. So please look out for that, and please note that you need to complete both of them. You'll have until 5 p.m. on the 6th of October to get them completed, and then give us 3 to 4 weeks after that to get the certificates out to you if you would. So at this point, I'm going to turn it over to Donnie.
Yeah, and Marty, may we drop, there's also a pre-survey that we'd like you all to complete, and it was included in your registration link. But if you haven't filled out the pre-survey yet, Marty or Jamie, can you all drop that link in the chat so that folks can complete that? Okay, very good. The pre-survey will only take you a minute or two, and you can complete that as we're launching the presentation. So it's a pleasure to have all of you with us this morning. As Marty shared with you, I am with the Area Agency on Aging of North Central Texas, and Jamie is a grant manager with our agency. And dementia is a topic that's of tremendous professional interest to me, having dedicated 35 years of my professional career to aging issues. I also have some lived experiences as well. So my dad passed away from dementia a few years ago, and my mom was recently diagnosed with dementia as well. So if we can advance to the next slide, I would like to let you know that today's program is based on Dementia Live, which is a program of Educate, and it's usually done in a live setting, and it's a lot of fun. If you're new to the program and you're interested in a live training, please let Jamie or me know. We are based in the Metroplex. We are willing to bring the program to professionals as well as family caregivers as our schedules allow. And when we come out, we have special gear that we use. I would like to let you know that we have adapted the Dementia Life program for Dementia Friendly North Central East Texas, and Dementia Friendly is supported by a federal grant with the Administration for Community Living. And we've got some more information about that grant on at the end of the presentation. So if we can advance to the next slide.
Real quick, if I can ask Jamie to, Jamie, could I get you to share that in this chat? The computer, I can't access the email with it because I've got the slides on that
Are you
computer. I'm
talking about
sorry, that's my mistake.
the
The
survey?
survey monkey, yeah, the
survey, the advanced survey.
Yeah.
I'm so sorry.
Alrighty. And then I did want to remind you that if you have some gear available, this program will be more impactful. And ideally, please have handy a pair of sunglasses, a pair of gloves, a beverage, your wallet or purse, pad of paper, pen, paper clips, sticky notes, cell phone, and magazine. And we will ask you to use those props in just a few slides. So again, would ask for your indulgence in completing the pre-survey and then gathering as many of those materials as you have available. So we will advance to the next slide. So I'd like to share some very basic information about dementia. If you've been in the field of aging for a while, this is information that will be familiar to you. But even if you are extremely knowledgeable about dementia, we hope that today's program will at least share some new resource information. So when we talk about dementia, we're not talking about a specific diagnosis. We're talking about an overall term that describes a collection of symptoms. So dementia is characterized by impairments of not only memory, but also language, problem solving, and thinking, and that impairment has to be significant enough to interfere with daily function. So if I have a difficulty launching a Zoom webinar, that's not necessarily indicative of dementia. But again, we're looking for significant changes from baseline that does impact our ability to function. Dementia is also characterized by gradual progression over time. If we go to the next slide. So I've talked a little bit about what dementia is. I'd also like to state what dementia is not. So as suggested, not a specific disease. It's not a part of normal aging, although advancing age is a risk factor. The older we get, the greater risk that we will develop dementia. As noted, it's not a problem with memory only. It has to affect function and problem solving and thinking. Dementia is not curable, although it is treatable. And that's one of the messages that often gets lost with family caregivers in particular, as well as healthcare professionals. And dementia is not temporary or reversible. So there are lots of challenges associated with diagnosing someone with dementia. It tends to be a complicated process, and it's considered a diagnosis of exclusion. And more specifically, ruling out other conditions that may present with dementia-like symptoms. So one of the many other conditions that can present with confusion are infections, and more specifically, urinary tract infections, medication side effects, particularly as people are taking more and more medications that may interact with each other. They may cause confusion. If we've got a diet that is deficient, that can cause confusion. Also, endocrine disease can affect cognitive function. And so we always want to see if somebody may be dealing with blood sugars that are too high or too low, or somebody may have thyroid function that is out of whack. Depression has been referred to by some healthcare providers as pseudo dementia. It can look a lot like dementia, but unlike dementia, depression is treatable and reversible. Also, dehydration can cause confusion as well. I mentioned that my mom was recently diagnosed. She went through a really rough patch where she had delusions and hallucinations, and her doctors were very quick to assume that she had dementia, and actually she did, but 90% of her problems were caused by a UTI, adverse reaction to opioids, and dehydration. And once those issues were treated, lo and behold, her cognitive status improved greatly. So again, it's really, really important whenever somebody is experiencing significant changes in memory or cognition or personality to have it evaluated and check for these reversible, treatable conditions. We can go to the next slide. So just to drill down a little bit in terms of those diagnostic challenges, um, most people who are living with dementia have not been diagnosed. They've never seen the doctor. They've, in some cases, they've not seen any doctor. And among those 45% or so of people who are diagnosed, only about half of persons with dementia are informed of that diagnosis. So if you do the math, about 3 out of 4 people living with dementia have not been informed of that diagnosis. And unfortunately, ageism is real. In many cases, people, as they grow older or their family members, may attribute confusion or problems with thinking or problem solving to dementia. And so they don't mention it to their doctors. They're not evaluated for it. And that's really a travesty because, again, there's so many other conditions that can be confused for dementia. And also, healthcare providers can misdiagnose if they don't conduct a comprehensive assessment. Um, if they're making a diagnosis based on symptoms only, and they're not doing a comprehensive dementia assessment, they really may miss the boat. We've seen that time and time again. So if we go to the next slide. As we're talking about a thorough dementia workup, it should include a thorough medical history, lab work to check for, again, diabetes or urinary tract infections. It should include a depression screen. It should include a cognitive assessment. And in many cases, that workup will include some imaging as well. So again, it's really important that that the diagnosis not be made on the basis of just a few self-reported symptoms. If we go to the next slide, it's important to know the type of dementia. And again, dementia is just it's just a broad classification. It's not a specific diagnosis. And so a thorough diagnosis is necessary in order to determine the type of dementia. And some people say, well, why does it matter if I can't be cured? The type is really important to plan ahead and know what to expect. Different types of dementia present differently, have different stages, have different courses of treatment. And so I've always believed that knowledge is power, and also kind of understanding the type and the course and the stages is important to know when symptoms are atypical and require further evaluation. So if we go to the next slide, These are not the only types of dementia, but these are the major types of dementia. And among those major types, Alzheimer's is the most prevalent. So about 60% of people who are living with dementia have dementia of the Alzheimer's type. And in terms of Alzheimer's dementia, it's characterized by plaques and tangles in the brain. The symptoms vary by stage. With mild dementia, symptoms may include wandering, getting lost, may include difficulties doing math or reconciling a checkbook. And during the moderate stage, people typically start to develop problems recognizing friends and family, may start to experience issues with impulsive behavior. And then in the severe stage, it becomes very, very difficult to communicate. In terms of age of onset, it's generally age 60, 65 plus, but it is possible for people to have early onset dementia, and particularly among people who have Down syndrome, they're at greater risk of developing dementia. And it's possible for people with Downs to start developing Alzheimer's as early as their 30s, 40s. For people without Downs, early onset, some people may start developing symptoms as early as their 40s, 50s. Frontotemporal dementia affects about 10 to 20% of people with dementia, and it presents a little bit differently. In terms of symptoms, it might present with changes in behavior and emotions that might include problems planning or organizing, impulsive behavior. Frontotemporal dementia tends to affect kind of emotional expressiveness in either direction. So some people will have very flat emotions, others will have excessive emotions. And it also is more likely to affect movement. So symptoms might include shaky hands, problems with balance and walking. It also affects language as well, where people may have difficulty forming or understanding speech. And the age at onset tends to be a little earlier than Alzheimer's. Generally, the age of onset is somewhere between 45 and 64. Lewy body is a even less common form of dementia, affecting about 5% of people with dementia. And the symptoms include cognitive decline, which may include problems concentrating or staying alert. It affects the ability to organize, form logical ideas. It also affects movement. And so with Lewy body, you might see rigid muscles, loss of coordination, reduced facial expressions as well. And one of the differences with Lewy body is there are more common visual hallucinations, seeing things that aren't there. Age of onset with Lewy body is generally age 50 plus. And then vascular dementia affects about 10 to 20% of people with dementia, generally caused by a stroke, but also can be caused by transient ischemic attacks or TIAs. And symptoms include forgetting current or past events, losing items, having problems following instructions, learning new information, having hallucinations or delusions, and impaired judgment. And with vascular dementia, it generally affects people who are age 65 and over, but it can affect younger people who've had strokes as well. Alrighty, so now if the technology gods are smiling on us, we will we'll display a very brief video just kind of showing.
What is Alzheimer's disease?
Alrighty, so it sounds like we've got audio.
You ready to go?
Yes, thank you.
Okay, I'm sorry.
You're good.
Oh, but it's not. But you're not seeing it.
Not yet, no.
Just 1 second, please. I'm going to have to unshare. Sorry.
And again, Marty and friends, if you're not able to display the video as well, you all will be receiving a copy of this slide deck. It's a very short but kind of well done depiction of how, yeah, here we go. Super.
Alzheimer's is a slow, fatal disease of the brain affecting 1 in 10 people over the age of 65. No one is immune. The disease comes on gradually as 2 abnormal protein fragments called plaques and tangles accumulate in the brain and kill brain cells. They start here in the hippocampus, the part of the brain where memories are first formed. Over many years' time, the plaques and tangles slowly destroy the hippocampus, and it becomes harder and harder to form new memories. Simple recollections from a few hours or days ago that the rest of us might take for granted are just not there. After that, more plaques and tangles spread into different regions of the brain, killing cells and compromising function wherever they go. This spreading around is what causes the different stages of Alzheimer's. From the hippocampus, the disease spreads here to the region of the brain where language is processed. When that happens, it gets tougher and tougher to find the right word. Next, the disease creeps toward the front of the brain, where logical thought takes place. Very gradually, a person begins to lose the ability to solve problems, grasp concepts, and make plans. Next, the plaques and tangles invade the part of the brain where emotions are regulated. When this happens, the patient gradually loses control over moods and feelings. After that, the disease moves to where the brain makes sense of things it sees, hears, and smells. In this stage, Alzheimer's wreaks havoc on a person's senses and can spark hallucinations. Eventually, the plaques and tangles erase a person's oldest and most precious memories, which are stored here in the back of the brain. Near the end, the disease compromises a person's balance and coordination, and in the very last stage, it destroys the part of the brain that regulates breathing and the heart. The progression from mild forgetting to death is slow and steady, and takes place over an average of 8 to 10 years. It is relentless and, for now, incurable. Helping your family, friends, and neighbors to better understand Alzheimer's will reduce stigma, improve care, and even help the fight for a cure. Thanks for helping to do your part. Learn more at www.aboutalz.org.
All righty. So I take issue with the patient. So obviously created for kind of a medical community. You know, one of the things that's really important to me is that, you know, we always keep in mind that people with Alzheimer's are first and foremost people, not patients, not Alzheimer's patients, but people. So we are going to go back to the slide deck, and here's where we get to the experiential part of the training. So hopefully you all have your materials nearby. Again, it will work best if you have sunglasses, gloves, beverage, wallet, pad of paper, pen, paper clip, sticky notes, cell phone, and magazine. And, oh, I'm sorry, I'm jumping ahead just a little bit. So I did want to kind of share some results from a focus group, a series of focus groups that I did a few years ago. And this really sparked my my desire to better share resource information with physicians in particular. So I conducted a series of 9 focus groups, kind of targeting rural counties. And I asked family caregivers about their experience in their family member being diagnosed. I asked about their experiences in trying to find resources. And among those 60 family members who participated, not a single one received any resource information upon diagnosis. There was one family member who was told, guess you need to start looking for nursing homes. And another who said, well, it's going to get worse and then she'll die. See me in a year. Imagine how you would feel as a daughter or a husband or a granddaughter being given this diagnosis, which is heavy, and being offered absolutely no support whatsoever in terms of education or resource. So my life's desire has been to kind of connect. Oh, Marty, I'm not muted, am I? And
No, you're not.
And get the
No, this
resource
is
information into the hands of healthcare professionals in particular, but healthcare professionals broadly defined, recognizing the critical role that home health social workers and nursing home discharge planners and others play in terms of bringing resource information to people in need. So if we go to the next slide, here's where we get to the experience. So again, I hope that you have those materials handy. We're going to start a soundtrack, and then Jamie's going to give you some instructions.
All right. Can everybody hear me?
Yes.
Okay, great. Okay, so if you could go ahead and just make sure that your volume on your computer is normal. I just want to make sure it's not too low. So you're going to be able to hear the soundtrack, and I'll be talking through the soundtrack.
So glasses on.
Oh, wait, one
gloves
second.
on.
Don't start it. Don't start it yet. 1 second. Okay, so yeah, go ahead and put your sunglasses on and your gloves, and you're going to be following along with me as I ask you to do some task. Okay, and you're going to be giving task without you're going to be giving task once the soundtrack begins. Okay, you can go ahead and start the soundtrack. Let's start by digging into your wallet and finding your driver's license. Once you've found that, write down your number and the expiration date on the pad of paper. Next, let's pull out your favorite friend, your cell phone. When you send a short text to a loved one and tell them what you're doing now, you have a magazine or a book in front of you, so turn to page 13 and read it out loud. The first line of text might be an advertisement, so just go ahead and read that out loud. Now, I hope everyone is taking care of what I've asked you to do with your license, and surely you've sent that text. Oh, let's take a quick break and grab the water or tea. Take a sip because you aren't finished. Let's find those sticky notes. Please write one task on each of 2 notes of things, and you must get done before the end of the day. When you are finished, just stick those up on your computer so you have a reminder. Now, let's get back to your cell phone and find that calculator. Can you add 21 plus 36 and then subtract? You know if you need to do this, or you know you need to do this on your pad of paper. That's perfectly fine. Just go ahead and work on those numbers so you can come up with the accurate answer. With your paper clip, please grab that magazine or book and flip 5 pages together, and then you can set that aside. Get your pad of paper out, write 2 words that describes how you are feeling right now. Oh man, what is that noise? You can put your license back in your wallet. When you do that, check and see if you have any bills or coins. If you do, can you get those out and just place them in front of you? Maybe pull out your car keys. Now, once you've pulled out your car keys, you've checked your wallet, checked your driver's license, and you've gone through that magazine, it's now time to tidy up your desk now and make sure everything's in order. Tidy up your desk because now we are finished. Okay, you can go ahead and end the experience. You can stop that. Go to the next slide, Marty, and it should stop. Okay. Go back. Go back to that slide. Maybe it'll stop.
Yeah,
Okay.
there we go.
Okay.
So everybody's on mute, so it's difficult to kind of discuss, but I would invite you to insert into the chat any initial reactions that you may have had. And if we do the live experience, it's even more intense.
You go to the 2 more slides up, Marty.
I'm sorry, I'm going to stop sharing my screen.
Yeah.
I'm going to share my sound because no matter how I advance, it won't stop. I'm sorry.
I see. Oh, you're good. Okay. That's weird.
Hold on, stop.
Yeah.
Okay. Okay. It stopped.
Okay. There you go.
Panic, overwhelmed, anxiety provoking, difficult to do with a short timeline. Okay, very good. If you got your driver's license out, you did well.
Yeah.
I'm still looking for my
Definitely
license.
passed that test.
Yeah, not able to keep up. How might the experience change the way that you respond to someone with dementia? Yeah, the background noise did make it very difficult to focus. The pace, was pretty brisk. There were lots of commands just kind of being thrown at you. Patience and compassion, absolutely. Compassion, that's really the goal that we're all seeking. Slow down, be patient, very, very important. One thing at a time, absolutely. Go slower, repeat. Excellent, you guys did great. Empathy, yes, that's also our goal as well. So if we can go to the next slide. You may wonder, well, how does dementia affect my hearing? It doesn't really affect hearing per se, but as we get older, hearing loss is normal, and hearing loss is a risk factor for dementia. What really changes with dementia is our ability to kind of interpret the sounds that we hear. So again, if we don't have hearing loss, we can hear the information okay, but dementia does affect that ability to kind of interpret that stimuli. So dementia actually does affect touch. So wearing the gloves was kind of a rough simulation. With dementia, it does cause loss of sensation. And so that can result in problems figuring out if the bath water is too hot, and diabetes can affect sensation as well. So if somebody has both diabetes and dementia, it's really important to make sure that the environment is safe, that the water heater is not set too high so that a person gets burned when taking a bath or shower. Dementia does affect vision and results in peripheral field loss that can also be caused by macular degeneration. It makes it more difficult to kind of see contrast sensitivity. So if you have a white plate on a white tablecloth, the person with dementia may have difficulty seeing that plate. It also results in difficulty with depth perception as well. And one of the tips I learned many, many years ago when I was a hospital social worker is that for people who wander, a lot of times just placing a black mat in front of the door can serve as an effective barrier, because the person with dementia may perceive that as being a hole in the floor and won't want to step over it. So if we go to the next slide, let's talk a little bit about some indicators that someone may have dementia. So keep in mind that dementia usually has gradual onset. With vascular dementia and a stroke, it may be more sudden, but in general, you're not fine and then wake up the next day with symptoms of severe dementia. So it's really important to know the history and have sudden changes evaluated to rule out delirium. Look for infections, look for medication interactions. So general indicators include recent financial difficulties, and one of the first abilities that's impacted by dementia, specifically dementia of the Alzheimer's type, is the ability to perform math. So if somebody is, is not keeping up with checks, is not opening bills, if the utilities have been shut off, those may be signs and symptoms of dementia. If we go to the next slide. Also, lack of orientation to time, place, and situation, problems concentrating or answering appropriately. But it's really important to keep in mind that that differential diagnosis is critical, and one of the things that a good doctor should do is evaluate for hearing loss. We saw this with my dad, who again died of dementia, but he had hearing loss many, many years prior to developing dementia. And people were quick to judge him because they would ask a question and he would answer inappropriately, not because he'd lost cognitive ability, but because he had about 10% hearing in his good ear, and he would just, he would answer questions that weren't really asked just because he couldn't hear them well. Also, poor recall of recent events. The Dementia in 3 Minutes video kind of pointed out how that's, that's a symptom of early dementia. If there are significant changes in housekeeping or personal hygiene, those should be evaluated. And again, as part of that comprehensive diagnosis, the healthcare provider should screen for depression. Repetitive questions can be signs and symptoms of dementia. And if we go to the next slide. So let's talk a little bit about communicating with people who have dementia. And you all have already identified many of these techniques after going through that very, very brief simulation. So it's important to speak slowly and in a reassuring tone. And if you ask a question and you kind of get a bizarre response, it's a good idea to use the same wording. And if that doesn't work, then wait a few minutes and rephrase. That may indicate a hearing problem, or it may be a sign and symptom of dementia. You want, if you're talking with somebody face to face, it's really important to maintain good eye contact with that person. You want to use short, simple questions, ideally those that can be answered with a yes or no, kind of one question, one command at a time, as opposed to Jamie's take out your wallet and your license and send a text, just one thing at a time. Because with a person with dementia, by the time you've gotten to the end of your instructions, that person has likely forgotten the directions. So it's also important to try to limit distractions. And you all experience that with the soundtrack. So if you're talking to somebody and the TV is on or the radio is on, or you're in a noisy place, it's important to, ask, can I turn off the TV radio, or go to a place where there's not quite so much background noise. We go to the next slide. One of the key principles in working with people with dementia is do not argue. If somebody is telling you something that is not true, they're not trying to be difficult. It's just that is their reality. And I mentioned that I've been in the aging field for a long time. When I started, kind of the the general guidance was reality orientation. You need to constantly remind people, hey, today is Thursday, September 29th. But that thinking has changed. There's really nothing to be gained by constantly reminding someone that that their mother is dead and is not coming to visit them. So you just want to go with their reality. You also want to be mindful of your body language, which tends to have even more impact than our language, particularly when you're talking with somebody with limited language abilities. You know, keeping in mind the importance of the nonverbal communication. You know, as best you can, it's important to smile, be positive, and to validate the feelings, even if what somebody is telling you is clearly not true. Again, in that person's mind, it is. And it's important to respond to the emotions rather than the words. Oh, you say your mom is coming to visit you, you know, tell me about your mom. You know, what are some of your favorite things to do with your mom? Tell me about your family. Um, and then also be mindful that all of us need to be respected. So I want to talk a little bit about some of the unique challenges encountered by family caregivers of people with dementia. They generally provide care for longer duration. Dementia tends to be a very slow, gradual process. So over half of family caregivers provide care for more than 4 years. Uh, Dementia affects personality, really the essence of the person, in addition to physical function. So family caregivers of people with dementia are at greater risk of anxiety, depression, tend to have poor quality of life compared to caregivers of people without dementia. They're more likely to deal with what I call in quotes problem behaviors or behavioral expressions. More appropriately. So more likely to deal with issues that include resisting help, hitting or biting, wandering, less likely to get help from family or friends. And if we go to the next slide, tend to be more likely to have problems with disrupted sleep patterns, altered eating patterns, more likely to turn to kind of cookies and alcohol as a form of self-medicating, more likely to experience headaches, back pain, more likely to rely on over-the-counter pain medication, and again, greater risk of irritability, fear, and anxiety in addition to depression. So it's not an easy journey for family members. And so those of us who are caregivers, it's important to kind of, you know, check in and see how we're doing. Those of us who are healthcare social service professionals, it's really important to be aware of the symptoms of caregiver burnout. And those include just having a very short straw, being impatient, getting easily upset over small issues. Also, a sign of burnout can be withdrawal from social activities. So if there's a family caregiver who had been very active in her faith community and is no longer going to church, or somebody who seems to be losing compassion and empathy for the person with dementia, those who resent the person with dementia, those who neglect or mistreat the person with dementia. Those are kind of classic signs and symptoms of burnout. So what can we do if we're a caregiver who's getting burned out, or if we're a helping professional? Again, really important to understand the unique pressures that may be brought to bear on family caregivers, and also help family caregivers understand that although there's no cure for dementia, there are a lot of things that can be done. Some very simple most that don't cost anything that they can do to better manage the care of a person with dementia. And again, kind of one of the key concepts is don't argue, don't engage in reality orientation, don't insist that your mom who's been dead for 20 years is coming to visit you. It's also important to learn what triggers those behavioral expressions and realize that people with dementia often communicate through actions rather than words. The portion of the brain that deals with language has been compromised, and so that wandering is taking the place of being able to articulate, I'm bored, I'm looking for someone, I'm looking for something. Um, you know, that that resistance to bathing may be a way of communicating, I don't like I don't like being undressed. I don't like feeling the way the water feels on my back when I don't know what's going on. Another key concept in working with people with dementia and family caregivers is understanding the tremendous power of distracting and redirecting someone. If there's a task that's frustrating or a situation that's heating up, oftentimes the very best thing you can do is to say, don't worry about brushing your teeth. Don't worry about, doing this task. Let's take a little walk with my dad. Kind of the solution when all others failed was, hey, Dad, would you like some ice cream? And, he almost always responded to ice cream. Also, it's important to consult the doctor as new symptoms emerge. They may be part of the disease process, but they may be treatable, or they may be caused by other conditions such as, again, problems with diabetes, thyroid, medications, and so on. And those certainly need to be evaluated and treated to the extent possible. People with dementia, it's really important to maintain a regular routine, to provide meaningful failure-free activity, to promote a regular sleep schedule, to avoid napping, because that can contribute to sundowning, people, wandering at nighttime. It's also important to age-proof and dementia-proof the home. So with my dad, one of the key things that we had to do was get all of the guns away from him, because he thought there were strangers in his house who wished him harm. And, he always armed himself and didn't always remember that he was married and that I, as his daughter, was an old woman who was coming to see him. So also important to remove other safety hazards, to kind of control access to medications and knives, and remove trip hazards as well. And then one of the messages that's really important to me as a provider of community-based services is to encourage greater knowledge of dementia and formal resources. So to that end, Marty, if we can go to the next slide. And then before I review these resources very briefly, it is important that to understand that relationships with clients, family members benefit from empathy and compassionate presence. And both of those are skills that can be learned or enhanced. And empathy is our ability to kind of sense what somebody else is feeling and imagine what he or she is feeling or thinking. And then compassionate presence is that ability to connect with the person rather than disease and accept his or her reality and experience. So next slide. So I want to talk a little bit about formal resources, including the Medicaid program. So the Medicaid program will pay for in-home services. For adults, yes, aromatherapy can be very impactful. So for adults who receive full Medicaid benefits, there's a program through the health plan called Primary Home Care. and that provides attendant care. For people who qualify for the STAR Plus waiver, and in order to qualify for STAR Plus waiver, the person has to qualify medically for nursing home care. Not that the person ever has to go into a nursing home, but that waiver will pay for attendant, personal assistance, respite, minor home repair, home delivered meals, and so on. So if the person you care for or your client is receiving full Medicaid benefits, and needs some help in the home, it's important to contact the Medicaid health plan, Amerigroup, Molina, Superior, United. For those people who don't receive full Medicaid benefits, but do have low incomes and limited resources, for a single person, no more than $2,742 a month in income, no more than $2,000 in resources, and additionally, needs help with at least one activity of daily living, transferring, walking, bathing, dressing, toileting, grooming, feeding. The community attendance services will pay for in-home services that can include both housekeeping as well as personal assistance. We go to the next slide. Area agencies on aging. So I have a little bit of bias here. I am with an area agency on aging. Hopefully, most of you are familiar with the area agencies on aging. If you're not, they provide services for caregivers of people age 60 or over, or caregivers of people of any age with dementia. And a couple of the major services I'd like to note include temporary case management. Area agencies on aging can also provide counseling, training, and education for family caregivers. In addition, area agencies on aging provide all kinds of services for people age 60 and over, including home delivered meals, congregate meals, transportation, temporary case management services, which can include homemaker personal assistance, minor home repairs, medical equipment and supplies, emergency response devices, temporary financial assistance. So please keep your area agency on aging in mind as a resource, regardless of whether you're a family caregiver or a professional. Aging and Disability Resource Centers provide information about long-term services. They administer a lifespan respite program, and they also help people understand Medicaid and provide assistance in applying for Medicaid benefits. The Alzheimer's Association Helpline is a wonderful resource, and through the association, it provides dementia information, education, and also sponsors a number of support groups. If we go to the next slide, I'd like to talk a little bit about dementia-friendly services. And I'm thrilled that we have a statewide and actually international audience today. These services were initially made available in North Central Texas only, but we have gotten permission to provide these services to family caregivers of people with dementia throughout the state of Texas. So we have compiled resource information for people with dementia, and it covers statewide resources. I'd also like to say just a couple of words about resources for enhancing Alzheimer's caregiver health. That's a program that assigns a dementia educator to provide one-on-one education and support. People are enrolled in that program for usually 4 to 6 months, and throughout the REACH program, the dementia educator will help that family caregiver problem solve. So if a daughter is struggling with a mom who doesn't want to take a bath, is getting combative, is wandering, the REACH program will help that family member try different things to respond to those behaviors. We are also partnering with James L. West, which is doing dementia live classes for family caregivers of people with dementia. It does the classes live with the full gear. It also does a similar workshop as this one, um, but it's kind of truer to the original and allows more time for the family members to kind of talk about their experiences. James L. West also does a 1-hour workshop called Compassionate Touch, and that teaches family members how to use touch to communicate with somebody who has dementia. And with that, I will share our contact information. I'm at dgreen@nctcog.org. Jamie is at jharwell@nctcog.org. And then Marty, I believe the last slide is actually the funding attribution. Did want to let you know that these services and this training program are supported by a special grant from the Administration for Community Living, and this information does not necessarily represent the views of the federal government, nor is it endorsed by the federal government. So with that, we are almost at our stopping point, but I will stay on if you guys want to ask any questions. And again, we will need you to please complete the 2 post-survey links, one with SurveyMonkey and the other for Google.
And that I just put the post test in the chat just in case.
So Miriam asked, is REACH national? REACH is, through this grant, we're making it available to all caregivers in the state of Texas. I would say if there's a caregiver beyond the state of Texas, we can probably assist as well, because this grant is all about bringing new services to people. So I would say reach out to us if you're beyond the state of Texas and interested in REACH. We'll see what we can do.
I'm going to put up here that real quick that we're going to be doing this presentation in Spanish next month. So any of you that can help us get the word out about that, that would be great. We're doing that in partnership with the James L. West. But I also want to point out that we have a lot. We're recording this, and it will be on our YouTube channel. But we have a lot of rich topics that the James L. West Center has done with us on our YouTube channel that are recorded that you can go back and look to. And one of them is dealing with difficult behaviors, emotional and physical behaviors with dementia. Did you all want to go through any other?
Let me see if we have any questions. I don't believe.
Yeah, I
didn't see any.
The one thing someone asked about you using it for family, again, we'll be getting this recording up, and obviously you can reach out to Jamie as well in regards to that if you're needing to do this for family members. But the recording will be up. It'll probably be a week or so. I'm out of town right now on a conference, so it'll be sometime middle or late next week. I'll have the video recording processed and uploaded to the YouTube channel. And
yeah,
please
and there is a great
that,
question about the sensory experience in dementia, and kind of teasing out or trying to understand why it presents only within a dementia-based delusion. And I would say it's important to have that evaluated. Dementia so affects the ability to communicate what's going on. And I know in my dad's last days, we were saying to the hospice nurse, boy, his eyes are really watering. And the nurse said, honey, he's in pain. And, he wasn't, moaning or kind of, giving us any, any indication that he was in pain other than, his eyes were watering. So I do think it's important to, to again make note of symptoms, to have those evaluated. It could be that that experience of severe pain is real, or it could be that just the memory is so powerful that it's kind of triggering that pain reaction.
I would like to point out, and I did this in the chat, I should have done this at the beginning of the webinar, I'm sorry, but if you had downloaded the slides for today's presentation, if you downloaded them before about 9 o'clock this morning, there was a mistake with the slides, and I apologize that there was a new set uploaded, and you use the same link, but you would want to re-download those slides to get the proper slides for this presentation.
Yeah, I had sent Marty my Adult Protective Services slides in air. Did I mention I'm the child of dementia? Well, that's not right.
Well, you don't have dementia because you remembered which one you sent me, right?
That's right.
So you're good.
Goodness.
You're good. But Donnie, Jamie, thank you so very much.
Marty, I think there was a question in here about those survey links. They asked if they're going to be emailed.
Yes, they're going to be emailed out
Okay.
with a follow-up email. That's correct. Both survey links, along with links to the flyers for some upcoming webinars we have going on.
Okay.
Marty, before we wrap, I do see one question here that I'd like to try to respond to. How do I move from HSC waiver to STAR Plus waiver? So I would suggest start by talking with your HSC case manager. HSC has some waiver services that are not available in STAR Plus waiver. So you'd really want to understand, how the STAR Plus waiver services differ. Make sure that you're not giving up a service that you really, really want. But in terms of requesting STAR Plus waiver, what you would do is contact your Medicaid health plan, the Amerigroup, Molina, Superior, or United, and then ask that service coordinator to do an assessment for STAR Plus waiver, and he or she will know exactly what to do. It is important to keep in mind that you can only receive services from one waiver at a time. So it would be HCS or STAR Plus waiver. And again, you want to make sure that you're getting the benefits that are most important to you.
Great. Well, thank you again, y'all. Thank you so much. It was really very, very great, very good information. As you can see, lots of appreciation in the chat. But thank you all for joining us. Please look out for the first follow-up email, and the recording will come out. A link will come out in the second follow-up email sometime next week. There was another question that just popped up. What doctor should control the care? PCP neurologist?
Yeah. In terms of dealing with dementia issues, the folks who have received specialized training would be neurologists and geriatricians. And really, I have tremendous respect for both. That's not to say that a PCP can't diagnose, can't provide good care, but again, I would consider the gold standard as either a geriatrician or a neurologist.
Very good. And if you guys think of something that comes up after we log off today, you're more than welcome to email. Again, Donnie and Jamie's emails will also be in the follow-up email as well. Well, thank you all, and you all have a wonderful day.
Thank you.
Take care. Bye-bye.